Dr. Nikitha will be presenting an interesting journal on artificial intelligence, role of artificial intelligence in improving bile duct injuries, in prevention of bile duct injuries in laparoscopic cholecystectomy. Nikitha?
Yes, sir. Good evening, everyone. So the paper for today's article for today's discussion is on artificial intelligence in laparoscopic cholecystectomy. Does computer vision outperform human vision? It was conducted by Liu et al. It's a Department of Pancreatic Surgery, West China Hospital, Sichuan University, China. So the article is taken from the Journal of Artificial Intelligence Surgery Journal. It was the article was received in February 2002, revised in April, and accepted and published in April. About the journal, it is a subjournal of Open Access Journal Publisher. It started in 2021. Till now, only 47 articles were published. So, as we know, the impact factor and site score are calculated based on the history of the journal of last 2 years and 3 to 4 years. There are no impact factor and site score for this subjournal as of now. But the other journals of this open access publishing, the cancer journal has an impact factor of 3.7, which is very good, and site score of 5.5. About the article, so in the introduction, they initially established the fact that laparoscopic cholecystectomy is a gold standard for all the gallbladder pathologies, and they said that it's because of the bile duct injury, which is one of the most severe complication. There is an increased mortality and worsened quality of life, and incidence of bile duct injury was published as 0.2 to 1.5% globally. They emphasize that the bile duct injury is mainly due to experience and anatomic localization ability of the different surgeons, and they referred a study which involved 600 surgeons, which showed that 72.3% of surgeons had experienced bile duct injury or a near miss, nearly half of whom they acknowledged that misrecognition of anatomic landmarks was the leading cause of BDI, especially cystic duct and common bile duct. Between them, they couldn't differentiate. Hence, appropriately identifying pivotal structures, including cystic duct, cystic artery, and common bile duct, these were taken as an important point. And they commented on computer vision and its use and the recent research in the medical field. So, analysis of the surgical videos, which contain large amount of visible intraoperative information and other pivotal structures. So, the history of 30 studies which demonstrated that computer vision could process a massive number of intraoperative findings has gained to gain valuable information. So with this information, they tried to apply it to the anatomical identification, so which would further help us in automatically identifying the structures during the surgery. So aim of their study was to verify the potential of this guidance ability of the computer vision and compare it with the trainees and senior surgeons. Laparoscopic cholecystectomy videos were screened, and from them a anatomic data set was drawn out. It's the screening procedure and the data construction. It has taken place from November 2019 to August 2020. 60 lap cholecystectomy videos. These were prospectively collected and they were analyzed. It was done in West China Hospital of Sichuan. Video frames were extracted from these videos, sir.
It's Sichuan, not Sichuan.
Okay, sir. Sichuan. Okay. One frame per second. And these frames were annotated. I mean, they were specifically identified and denoted by 9 well-trained surgeons with over 100 laparoscopic video reviewing experiences. So they were again supervised by another senior surgeon. What the annotators work has done, and corrections were made. four important anatomical regions, namely cystic duct, cystic artery, common bile duct, cystic plate, were annotated. The software which was used was Anaconda 2019, and this study has been approved by the ethics committee. So this is how they had done the annotation. From a frame, they have identified the structures and they have put it in the box. And they did it for each frame. From those annotations, they derived an algorithm which is called YOLO, which is you only look once. It's for the object identification. So it's like every frame they process, and on each scale they separately identify the structures. Like understanding and multiple object detection ability of the model, a data set is created and it was used for pre-training and transfer learning. The technical details were mentioned in the article. This is one of the important point they have mentioned multiple times in the article. This is the main point of evaluation was area of intersection, which was divided by area of union. That is the area where the anatomic identification or misidentification mainly occurs. So average precision was defined as area under the precision recall curve. Additionally, the main average precision, which is arithmetic mean of average precision, was applied to evaluate overall performance of the SurgiSmart. SurgiSmart is the application which we are using in the study, the computer vision. So comparison between SurgiSmart and trainees were done. Trainees, the criteria was defined as who have watched less than 100 laparoscopic cholecystectomy videos, but without clinical experience. The seniors were defined as surgeons or attendings with greater than 100 laparoscopic cholecystectomy operation experiences. And the only 3 of the 4 anatomical regions were considered into evaluation. So during the assessing time, 28 intraoperative still images from 2 laparoscopic videos were included. And they have also included one other factor, that is corresponding time, which means during the surgery, at initial time and during the mid time and the final time, at different times they have taken the images and they compared at what point of time did the trainee or surgeon or the SurgiSmart algorithm has identified the image or the structures. So this is how they have divided an image, the frame, into boxes of 7x5, and this is area of intersection from the area of union. So this box would be considered as the right identification. So, the time point at which the earliest correct identification was done was recorded, as I have mentioned, and identification rate of 3 groups through chronological level, which means correctly one image in the whole set would be recognized as correctness. So they have used different tests to do the statistical analysis, most of them to minimize the most of them to minimize the variance between the observers, and some of them some of them are the comparison test. P-value less than 0.05 on both sides was considered as statistically significant with 95% of confidence interval. Critiques.
Nikitha, you can't give this thing critique. You have to ask them, no?
Yes, sir. Yes, sir.
Yeah. Ainas, we'll start with Ainas.
Yes, sir.
Ainas, you have attended previously, Journal Club. Last month you attended, huh?
So one I had attended.
Yeah. So you
last
at
month,
least
yes,
know
sir.
the basics, know what we do.
Yes,
So
sir.
can you tell us the critique? Anything? whatever you could understand.
Sir, like the study was conducted prospectively, which is like a plus point.
Okay.
That which was mentioned, but then the study as of now has like the journal in which it was
So
published has
start off with the basics, like what it is, which journal it is, and all that.
uh as in sir, like the impact, the journal has published 47 articles, uh and it does not have an impact
Impact
factor
factor.
yet.
Correct.
Yes,
Correct.
sir. So like that could be one of the drawbacks of the
Yes,
journal.
you can take it as a drawback, but the parent journal has a good impact factor. So that means probably the quality of the sub journal also will be good. So, but it is too early to say anything on that. Good. Then,
Oh, and like, so I
okay.
think like the aim was maybe defined well, as in
No, no. What about the
statistically.
Topic.
Uh, so it, like, with the emergence of artificial intelligence, it is like an important topic to be
So
considered,
it's a relevant topic which they have
relevant topic.
taken up. Yeah.
Yes, sir.
Hmm.
Uh,
Anything else?
so other than that, like, so yeah, like, uh, it's a recent study, sir. So re-
So
like
that
it
is
was
also a good
published
thing.
very,
Yeah.
yes, sir. Like
Okay.
it was published
Good.
relatively recently. So
Good. Hmm.
that's this is all I could think of as of now,
Okay.
sir.
Praveen,
And so, they included the criteria for trainees and the seniority
sorry.
based. Criteria for the trainee and the seniority they have explained.
No, I'm not able to hear.
Hello, sir.
Speak up, man.
Louder.
Hello, sir. I am audible, sir.
Yeah.
Yeah, no. Yeah, better.
Yes, sir. They have included the criteria for trainees and the senior surgeons. What are the
Okay.
criteria? And to
So is
minimize
it
the
good or bad?
risks, it is good, sir.
Okay.
And to minimize the errors, they have done with annotation with 9 surgeons. And to still minimize the error, they have again added supervisor to correct those. And
Okay.
they used various statistical analysis for the analysis of the data.
Okay.
Con is they
Hmm?
did not in the cons they did not include the criteria of patients what for what are that what diagnosis they have included the patients in the study.
Hmm. Eh, You mean like they have not mentioned about the diagnosis of like whether it is cholecystitis or what?
Yes, sir.
Okay. Anything else?
That's
What is computer vision, man?
sir.
What is computer vision? It is all based on computer vision, no? That software. So what is
Yes,
it?
sir.
If you don't understand that, then that software only you can't understand.
So, first, they have identified the structures.
No. What is computer vision? Nikitha said it is based on computer vision. Nikitha,
Yes, sir.
what is computer vision? You said it is based on computer vision, no?
Yes, sir. Computer vision is basically an artificial intelligence system or
Hmm.
field which completely deals with interpretation or analysis or um, application of uh, visual data, sir.
Correct. So it's a subfield of AI which uses digital systems which process, analyze, and interpret visual data. Like suppose it's like example for that is like in photographs in Google Photos, you can that will pull up all the faces with common. Like if it's your phone, it will give you the hints that this person photos are there. If you want to select that person, you will get all the photos. So that is how the machine learning happens, where you feed the data and the machine learns itself, and then it's able to this thing. That is what they want to use it, where they feed the videos in this and then they come up with that. Abdul, Sanya, any comments or any critique? Any other critique?
So they've involved, I felt they've involved a lot of people like trainees and surgeons and all. Doesn't it become too objective with it? Sir? Like, I mean, too subjective with it.
No, that is why they have taken two categories, this thing separately. They want to know whether it is accurate or not when by comparing with that.
Yes,
So,
sir. But
sir,
they will be
Ravi Shankar sir?
comparing it with,
Uh, I think for a very common condition, the number of videos studied are less. I think that is
Yes,
probably
sir.
the main critique I can think of. And
No,
also,
with respect to Sanya's this thing, can we take that as a critique?
see,
Trainee and experts.
I think this one is one. See, they have. See, I don't know. I don't think somebody doing 100 cholecystectomies, you can consider them as experienced surgeons. And second thing is, I don't
Hmm.
think you can call trainees people who have just seen 100 videos of cholecystectomy having not assisted it at all. So I think both of them. I think
Maybe they should have better qualified
yeah.
in
I
both
think what
groups.
they have done is they have chosen people whom they can easily beat by the computer and shown that computer is better than them. I feel.
Maybe
Shrikant?
bias, that is. Yeah. Shrikant sir?
Well, nothing to only thing is on numbers I'm this thing concerned. It is too
I
less.
think, see, for a very common surgery, and I think as Praveen has indicated, the identification of structures in a symptomatic gallstones patient to an acute cholecystitis patient to patients with more complicated empyema and other things is much more difficult. So that
Correct.
categorization, if
Correct.
it doesn't happen, then I think it becomes useless, because if you
It would
are,
have been it would have been better. Yeah.
if you are doing just symptomatic gallstones, I think even a person who's seen 10 videos will be able to tell you this is the cystic duct, this is the CBD in most cases.
That's
Only when
Correct.
it comes to
Correct.
very difficult ones, then I think if it is shown to be better, then it may be useful.
Correct. So they would have it is one of the commonly performed surgeries. At least probably some 500 also cases they would have taken. Probably the software would have had much more information with respect to difficult gallbladders, and they could have quantified like simple cholecystectomy, complicated for gangrene and frozen callots and all that. Then probably the software picking up the data could have been much more better, right? As you said.
See, just on the,
Anything else, sir?
just eyeballing things. If, for example, Niranjan, Shrikant, when you are doing surgeries, if for symptomatic gallstones, how often, when you ask your students, what is this? Have they not identified the structures correctly? I think most of the time they are
Yes,
able
sir.
to. Only in acute situations and in difficult ones where, then sometimes we even struggle with that after having done so many of them. So I think that is where the need for
Only
artificial
exception will
intelligence
be
may come in.
some alteration of the anatomy.
Yeah.
Yes.
Other thing is, Nikitha, you said, see, I think that is a slightly inflammatory statement. I see bile duct injuries are, very, I think the number is probably a bit high. With open cholecystectomy is 0.27 to 0.35. With laparoscopic cholecystectomy, it's 0.35 to 0.49. I think that is across the board. That is universally, accepted and established. So to say it is more
Usually
than 1% or
acceptable rate is less than
1.4% is wrong.
0.5%.
Second thing
Yeah.
is,
Yes, sir.
correct. And the second thing is the mortality. I think the mortality directly ascribable to bile duct injuries is very, very minimal. you said you made a statement mortality. I don't think there is mortality with it. There is reduction in life expectancy if you have a bile duct injury, where up to anywhere up to 10 years. That is the
Quality of life is more important.
quality of life and reduction in life expectancy up to 10 years. That is the main problem with bile duct injuries. Mortality is not the problem. Mortality is
Yes, sir.
only
Yes, sir.
in totally neglected, unrecognized bile duct injuries which go on for a few weeks or
Biliary
months
peritonitis.
and peritonitis, and then maybe. But otherwise, those kind of scenarios hardly ever happens. Moment patient is not doing well, you investigate them, you identify the bile duct injury, and then deal with them appropriately. If you can't deal with it yourself, send it to a center which deals with it. So by and large, there is no mortality as such. There is definitely morbidity, very significant financial implications, reduction, as Srikanth rightly said, quality of life reduction, and reduction in life expectancy. But mortality is not, I don't think, is a big deal. Nikitha, did you understand?
Agree, sir. Yes, sir. Yes, sir.
Okay.
I,
So whenever you
I think
make
she quoted
these
from the
statements,
paper.
Yes,
you
sir.
should be able to qualify. Otherwise, you shouldn't make statements like that. It's very, very wrong.
I
If it is,
actually tried to establish what the paper's introduction wanted to say, sir. I just commented on what
She's,
they have
she's
commented, sir. I
quoting
mean,
the
what
figures
they.
given there. They have given it as up to 1.5% bile duct injury rate, which is probably very high.
see, internationally,
1.5 is difficult gallbladders.
if you look at every journal, this one, the rates are what I have quoted. See, which is why that there is always a dilemma. The International Board of Ethics, mandate that any complication rate above 1% should be told to the patient. So on that count, bile duct injuries do not actually count to be actually counseled. But I think as this one, we do mention that. Okay, carry on.
Yes, sir.
Show your this thing.
Yes, sir. So my pro to the study where it was a recent study and a relevant topic with a prospective approach, and the trainee versus senior criteria was established. Though the
But
number
the
of
trainee
cases,
versus senior criteria, the qualification of the both the criteria groups probably is not perfect, is not correct, which is what we felt. So it's probably a con.
Okay, sir. And the huge data set, I meant to say by number of frames they counted, taken into the account. Though the number of cases were less, the inclusion cases, there were only 28 laparoscopic videos which were included, but number of frames were high. So the images which were fed into the algorithm were high. And using
No,
9
but
surgeons.
since it's a common procedure, we cannot call that as a huge data set because it's one of the commonest procedure, and them taking only 60K videos, and then out of that again they've excluded so many. So
Yes,
it's
sir.
probably not adequate to create a software accurately, like accurate software.
Nikitha.
It has become
Yes, sir.
more than hernias and appendix now.
Nikitha,
Yes, sir.
do you know the number of photographs and images that one, this one, the, what do you call that, the capsule endoscope takes?
No idea, sir.
Anybody? Sanya or Abdul? Take a guess, man.
Someone speak up.
Sanya, take a guess.
2000, sir.
Sir, can you
More
hear me?
than that.
Hello.
Everyone will
Yeah.
embrace you if it was 2000.
Sir, can you repeat the question? It got disconnected in between.
It is number of photographs and images that a capsule endoscope takes in its journey.
I'm not sure, sir.
Capsule endoscopy, huh?
4 to 6 lakhs. 4
Oh.
to 6 lakh images. So that is why I have actually met and spoken to the radiologist. He was from the South Manchester University Hospital called Widenshaw in Manchester, who actually, I think he was the one person responsible for introduction of capsule endoscopy. And everybody used to send the images to him. And he commented, I'm actually sick of this because I don't know why I invented this, because who goes through 6 lakh images, man? It's very difficult.
It
So
transmits around 2 to 6 frames per second, that capsule endoscopy. So minimum image by the time it comes out will be more than 50,000. So it can go up to lakh or more than that.
So that is why I think capsule endoscopy still has a role, but it is limited to, after having done all the other investigations, it is limited to those people where you can't identify it. Nowadays, the CT and MR and these images are, and then the endoscopy, enteroscopies are there. So these are overtaken. So capsule endoscopy role is very minimal. So similarly, these, whatever you said, the data set is not that huge. Understood, no?
Yes, sir. Yes, sir.
And
Okay.
that's why you will take like couple of days for them to give you the report after capsule endoscopy. Somebody has to sit and go through the entire range of images to point out the abnormality. It is not so easy.
Yes, sir. And shall I continue, sir?
Yeah.
Yeah, go on.
Yes. So they have included 9 surgeons and 1 supervisor for annotating the images. And explanation
Annotating.
annotating,
You are
right?
Annotation.
struggling. Annotating. It's
What
not
is the
annotating.
qualification of the supervisor?
They did not
They don't-
mention in the study, sir.
That
They
is
just
also a
mentioned it
negative.
as senior
That is
surgeon.
also like they have to qualify who is a senior surgeon.
Yes.
One place they have said more than 100 surgeries, lab colleagues.
Supervisor should be have a more qualification than the.
Yes, sir.
So
They
that
did
is
not
also a
mention
this thing.
any.
Yeah.
Yes, that's one of the corner.
Yeah.
And they tried to almost explain the model and the evaluation procedure in the simpler terms, the technological aspects of the study.
Okay.
And the cons being no inclusion criteria. The 28, as Praveen commented, the 28 laparoscopic videos where they did not classify whether they're cholecystitis or chronic cholecystitis or symptomatic gallstones or any other gallbladder pathologies. They did not mention about the diagnosis of them. That would make a lot of difference. And
Yes.
study was performed in 2 different centers. The data was from one center and the test videos were from the other center. And the equipment
No,
specifications
the
of
data can be fed from any center. It's about the type of surgery, like for what it has been done. So that doesn't matter.
but sir, my point was that if the camera equipment is different from the 2 centers, they did not say that they have similar
Correct. I
video
think that
quality from the 2 centers or
that
not.
may be valid. Yes.
Yeah, quality
In
may
that
be
case,
valid, but
yes, sir.
yeah,
In that case, it would make a difference from data versus test, sir. And there
correct.
were only 2 test videos which were included, though the like the training of the computer vision took 28 videos. For testing, they used only 2 videos, with one being with inflammation, the other being without inflammation. So only 2 is my con, sir. They could have done with more videos.
That is what we have been telling. So
Yes.
the numbers are less, whatever
Yes.
they have tried to do.
Yes, sir.
Yes, sir.
See, I think, all of you please understand the basis for, if you understand the principle of the, this minimum data set or this power of the study always, takes into consideration. If you go to a statistician and ask him to give you power of the study and to give you the number of patients you need to show a significant difference, in common conditions, he will ask you to do a lot more numbers. In rarer condition, he will ask you to do less numbers. So this is a very common condition. So you should have done a lot more studies before you can make conclusions. You understand, no?
Yes, sir.
Always the power of study depends on how common the problem is prevalent in the given population.
Yes, sir.
Carry on.
Yes.
So move on. I don't think there is any other critique.
Coming to the results,
Yeah.
they have summarized the result with a flow chart.
Why is it not visible full? It's moved to the one side.
No, sir. I made it into two parts because it's like
Okay,
this.
okay, okay.
So,
Okay.
so 60 eligible videos were recorded in the study period, out of which 19 were excluded and 41 videos were included in the study. And in them, 32 went into the training and 4 went into validation and 5 were the test. Frames were extracted from them, out of which few were excluded. Finally, they got data set which had 500 and 533 frames for manual annotation, and which were entered into our software Surge Smart. This is the flowchart of technical aspect. In summary, out of all the extracted frames of 41 videos, only 5,533 frames were selected. In those, they were randomly assigned to training and validation and test data. Most patients underwent elective surgery, and most patients were diagnosed with chronic calculus cholecystitis, and only 6 patients with acute attacks. The demographics of the cases were mentioned in the study. Surgery type and BMI and history of other comorbidities. Even the post-operative hospitalization, diagnosis, ASA grading, everything was mentioned. Coming to the comparisons, for the performance of Surge Smart, the mean accuracy precision for the 4 regions was 0.7. Specifically, AP of common bile duct, cystic, separate AP of common bile duct, cystic artery, and cystic plate were mentioned. Eight surgeons were involved in AI surgeon comparison. Among them, 32 participants were classified as trainees and 80 surgeons. I'm sorry for the mistake. 32 participants were classified as trainees, 36 were surgeons classified as seniors. Cronbach's alpha is 0.817 and 0.84 before and after excluding questions. Excluding questions were the some
What
of
is
the
that?
frames.
What is that Cronbach alpha?
It is a test which is to minimize the variance among when a set of
What is it?
people are included in a study to decrease to compare the variance of all the sample, it is used, sir.
So it is measure of consistency and
Consistency.
reliability,
Yes,
internal consistency and reliability. Yeah. So when you
I've told you always that whenever you introduce a new statistical method, it is better to put up a slide and explain it
correct.
that way.
Yes, sir.
Okay.
So it's
Okay,
basically used to determine if a set of terms consistently measure the same characteristic.
yes, sir.
Yeah.
That showed that they have a good internal consistency that minimizes the bias, and the validity of the test indicates mediocre construct validity.
What is it?
Validity of the test, sir.
Hmm.
It's mediocre, they have mentioned in the study.
I didn't
Okay.
get
I also didn't understand.
what does that mean, Nikitha?
Sir, if we reproduce the test again, that result will be in the not good but in a mediocre validity, I thought, sir.
No, but the previous sentence you said it's got good internal consistency.
Yes, sir.
So you can't call it as mediocre, no? Then.
Sir, this is of two different things, sir. The first one is about the internal consistency of the trainees and the surgeons separately.
Okay. Yes.
The validity of the test is for the overall the test
Which
of
test? Which test?
surgeon or trainee identifying accuracy per AP, some mean AP comparisons and all.
I didn't understand. Sir?
They didn't elaborate much on what test they have done. I assumed it to be of the basic AP test only, sir. Like the correctness, accuracy, prediction, and everything.
If that is mediocre, then you can't rely on that data, no?
Yes, sir. Yes, sir.
They have mentioned that it is mediocre. I didn't see that.
They mentioned it to be mediocre, but they did not mention for what specific test was this clearly indicated or.
Okay, I think I missed that this thing. Anybody else? Anya, Abdul, have you seen that?
I saw, sir, but I was not able to understand, so I was waiting for Nikita to explain.
I also didn't get it.
I think we'll all go through the paper again to see what.
Again, yeah. Okay.
Put it up in the group because
Yes, sir.
I can't remember this also. Yeah.
Kaiser-Meyer-Oken test
Go on.
and Bartlett test, which showed p-values significant.
No, what are those tests again?
These are the comparison tests, sir, between SurgiSmart and trainee, SurgiSmart and senior surgeon.
No. What is it? What does that Kaiser-Meyer-Oken test? What is it?
When I googled, all I could make out was it's a comparison test only, sir, between two.
See, why don't you just use a student t-test or, for example, chi-square test or Wilcoxon or Mann-Whitney U-test? Why are they brought this Kaiser-Meyer-Oken test or Bartlett test? There must be some specific characteristic for them to use this, no?
Yes, sir.
It is a test for measuring sampling adequacy, whether whatever the sample it is adequate or not, and it measures how suited your data is for factor analysis. The Kaiser-Meyer this in Olkin test. So it is better always, like all of you PGs, that whenever you come across a new term in statistics, it is better to put up a slide for that, as Ravi Shankar sir was mentioning previous this thing.
Yes, sir.
What is Bartlett's test?
Anybody has looked up Bartlett test? See, I've told you repeatedly that whenever you come across a new terminology, just Google it and then read it a couple of times and you'll be able to understand. Otherwise, we'll at least be able to discuss it. I think none of you have made an effort to do that.
So it is basically a test which determines if the variances which happen between multiple groups are equal or not. So it tests that Bartlett's test. See, these are not usual statistics which we come across. All of you people should have made an effort to study and understand. Then only we can understand the paper. Without the statistics, if you read that 0.000 this thing, nobody will understand what it is.
Sorry, sir.
Okay, move on.
And for each still image, the mean intersection of union of SurgiSmart of SurgiSmart trainees and seniors were calculated. In the two cases, one without severe inflammation, the other one with severe inflammation.
What is that mean IOU?
Mean IOU, sir, on an image of the overlapping two areas, the intersection area is considered to be the part where the proper identification need to be done, the annotated box. So,
okay.
So
it is intersection over
union, sir.
Correct. So the box where they will measure accurately or not. Okay.
Yes, sir. Which was statistically significant. Over half of the images.
What is it? Go back. Tell us again.
Sir?
Tell us again. What does that sentence mean? The last sentence. You said mean IOU.
Yes, sir. It's like if a SurgiSmart select 3 boxes and the trainee select the other box. If they select 2 more different boxes, but if there is one intersection, that point would be considered as intersection over
No,
union,
I
sir.
understood what is that. What does this signify? What does this sentence signify? What is the data signify in this?
No, Nikita, in the first place, what he said is wrong. What they basically it's saying is, if you determine a particular IOU to be the correct segment where you are supposed to identify all these structures, okay,
Yes, sir.
then in 0.561, this one, the SurgSmart was able to identify. On the other hand, only 0.2 for the trainees and 0.45 for the senior surgeons, which means the SurgSmart was better than the other two cohorts.
Yes, sir.
Correct. So the block which was supposed to be identified correctly, the SurgSmart identified that accurately in that 0.646, whereas the trainees in 0.275 and the seniors in 0.407. Whether it is significant, and it has shown to be statistically significant. The difference is there.
Yes, sir.
Go on.
Over half of the images witnessed statistically significant disparity between pairs of SurgSmart trainees and seniors, the interpretation of the previous data. And furthermore, according to IOU curves, despite there is a difference between them, the shape of the curves had similarities. That means if a surgeon found some a frame to be difficult, the same was for the trainee, and almost similar to in some cases by the AI. So these were the graphs. These are the frames at which the identification is the mean of IOU. This is without severe inflammation, and this is with severe inflammation. The significance was in with severe inflammation cases only. As we can see this graph. Correct anatomic identification. In without severe inflammation cases, SurgSmart had higher accuracy. And at chronological images, the correct identification rates at each anatomical level, like 88% for the seniors, and those trainees had 56%. In severe inflammation cases, the SurgSmart has 66% of accuracy, whereas for those trainees had from 8 to 75%. Trainees had 8% and seniors 75%. On chronological imaging, the common bile duct for trainees had 68, and for seniors was 94%. All these results demonstrate that accuracy of SurgSmart is in anatomical identification is significantly higher than seniors with a statistical significance.
Statistical significant difference between the two groups.
Yes, sir. But as you can see, the images which were shown to the AI were only like less in number, 4 or 5 images. And in the second case, there were only 2 and 3 images. But for trainees and seniors, the number of images which were shown were in hundreds, 128, 192, and in chronological 32 images.
Yes, move on.
Sorry, sir. I just think I misinterpreted this, or that this is number of images, sir.
Correct. You're correct. Whatever you said was correct.
Yes, sir. So, and for seniors, there were like 144 frames, and in some cases, 108 and 36 frames. Though the accuracy of anatomical identification was higher for AI, the number of images which were shown were less. Additionally, comparison results of earlier surgical phases and identification are depicted. Even though seniors tend to correctly identify the anatomical regions in earlier phases than trainees, except in cystic artery cases. The performance of SurgiSmart was superior to most of the surgeons, regardless of experience.
Now, have they given anywhere why they have said only such a low number for Surgery Smart?
No, sir. No, they just mentioned only in the table, sir. Nowhere in the text
Hmm.
they have commented about the number of images which were shown or the exposure.
See,
Okay.
what do you think might have happened, Nikitha?
Sir, if the AI has identified initially within the 4 slides or 4 frames, I think they might have not shown the further frames.
See, I think more than that, what probably they have done is the AI has been given the most, say most frames where the identification is easy, 4 frames, and they said, it is superior compared to the difficult frames which have been given to the surgeons, taking longer time and probably much more difficult. So they have not been able to be that accurate as compared to the Search Smart.
I think, sir, it would have been appropriate if all the 3 groups would have fed the same images, and then they
Yeah.
should have recorded
Correct.
which one is better,
Correct.
able to pick up this thing correctly, identify the frames.
I think that is what they have actually doctored the thing to say that the Search Smart, they have fed the most easily recognizable 4 frames and said it has recognized it all of them, as opposed to, see, I think see, if you
Is it
look at
company sponsored?
Allah, if you look at Nikitha, see,
Yes,
the
sir.
thing is, when you are operating, you are not seeing it frame by frame. The entire image is there. So
Still image.
the complete amalgamation of all the images, what you're seeing. You are not seeing only the pixels.
It cannot see individually.
So basically, if you just put up the first frame, which is near the what shall we say, the falciform ligament of the liver, and then say identify the CBD or identify the gallbladder, you can't. When you come up to the frame where there is segment 4 and the Cantley's line and all these things, only then you will be able to identify some of the structures. And I don't think practically we are only going to see one frame and say, come on, nobody is going to hold a gun to your head and say identify all the structures, because that is impractical. So to some extent, I think as Srikanth put it, it may be sponsored by the company, which is why they have have to show. Now, I am no doubt that artificial intelligence is going to be certainly helpful to us if in difficult cases, as we said. But I think the study needs to be a bit more robust and much more scientific than what they have done.
Yes, sir.
Go on.
Yes, sir. And this table is this charting is based on is about the chronological identification of the structures. So the detection time is plotted by the red line.
They have used complicated statistics and graphics to highlight their points, but looking at it in uh, uh, detail, points out that whatever we mentioned, that it looks like they're trying to push some push the this thing results with some agenda.
Yes, sir.
See, do you think if honestly, I take Niranjan's point that its parents journal has credibility, but if this data was very credible, they would have certainly got it published in one of the Journal of Minimal Access Surgery, or I think Journal of Royal College of Surgeons, if not BJS or Annals of Surgery. So they probably would have submitted it to it, and then it didn't get this one. And open access journals are easy to publish, so they have probably published it. And the fact that it has not yet been quoted, already more than nearly 2 years since it's published, it's not been quoted by anybody else. Now that the AI is expanding, so it's a almost explosion of AI. If this was credible data, I think it would have been taken up by others also.
Yes, sir.
Move on.
Critique of the results, sir.
I think, sir,
think-
we have discussed everything almost.
I put it, I think, is there anything, Sania, Abdul,
New.
anything you want to say?
So, like Niranjan sir said, all the results and statistics they've used seem to be very complicated. Maybe because you're not used to these statistics.
No. The statistics which they have used is absolutely right and appropriate,
But
and they're like more
yes,
complex. But to back that up, they don't have the data. So
that's what, yes, sir.
it looks like there is a bias to like push
Yes, sir,
that
yes,
AI is better than that software is better than this thing, and to identify
yes, sir, yes.
and prevent the bile duct injury. But we are not seeing the data, actual data, to like justify those sentences or comments.
Yes, sir. Also, like you mentioned about the sample, like the images shown to AI and then images shown to trainees and experts, gross difference between those two images, those two groups. Mostly.
Yes, Nikita, anything extra?
Nothing, sir. The criteria of randomization I've mentioned regarding the frames only, sir. Like they
Hmm.
didn't mention how they're giving the number of cases. Even if they're 4, what is the criteria of giving 4 to the AI, and
I don't think there is
while
any
32?
randomization here. They've given the sets of this thing frames. Not they've not given any patients by randomizing. I don't know. Where did you get this thing?
I meant to say that the number is less, but why that specific number they didn't mention. Kind of the randomization of questions, like the images.
See,
Yeah, that is what.
Yes, sir.
Sir,
Nikita,
Yes, sir.
you not understood the concept of randomization.
It is supposed to be for the how to take the sample. It is, yes, sir. I misuse the word. I get it, sir.
Yeah. It's not randomization,
so
it's
it's not randomization.
allocation of
Allocation.
the this one too, because
Frames.
randomization means you have different methods of randomization. Basically, you divide the given data into equal parts between the three groups, so that demographically and in terms of all other the confounding factors, they are all similar. Then you compare the groups.
Yes,
Here,
sir.
Here, if randomization comes, then your study will go for a toss. It would have been better if all the three would have been fed the same this thing data rather
Yes.
than different data.
Yes, sir.
and I think the extensive test it is a red herring. It is to confuse everybody. We have done a lot of tests and everything has shown that we are accurate. I think it is. I think there is a trick they have used. As Niranjan said, they are appropriate, but probably I think it is used to in a very clever way to show that the AI is better.
Yes, sir.
So what is the
Go
take-home
on.
message?
So the intentions and the purpose of the study was good, sir. But the
How do you
way,
know? How do you know
sir,
it's good?
because it's a very relevant topic, and it's
Correct, but the intentions were to prove that AI
Not
is
the not the
no.
intention.
I
The
mean,
purpose of
the
doing the
purpose
study
of the
was
study,
good.
sir.
the
Purpose.
concept was good, but the intentions were not.
It was not
See,
impartial.
Yes, sir.
if you can't take 100 people, 100 trainees who have not done any single gallbladder and call them trainees. How can you call them trainees if you just watch 100 gallbladder operation videos? You will not be, you can watch thousands. Unless you start doing them, you will not be able to identify.
I think if they had to accurately validate, it should be with the validation with comparison to experienced surgeons. The trainees, it doesn't matter because
They should
trainees
not have
may not
included
be
trainees here.
even. Yeah, the trainees will not be able to identify in complex cases. Maybe they may be able to identify in simple. But without any experience, if they're trying to create a software which will be helping us in detecting and preventing bile duct injuries, they should match the data or validate it with experienced surgeons rather than with trainees.
See, the other thing is, Nikita, I think this is well established the first 30 cases is the learning curve, and 30 to 50 or even 70, you are extremely careful because you've just, started doing it and you're starting to become confident. 70 to 100 is where you start becoming overconfident and sometimes even arrogant, thinking that you have mastered the art. So 100 is actually not a good number. If you should go beyond 100, you should go somewhere near 200, 250 to call a surgeon experience as far as gallbladder is concerned. Niranjan?
And probably, yes, sir, I agree. And probably that there is data also to show that the number of or percentage of bile duct injuries is probably more in experienced surgeons' hands rather than in relatively inexperienced surgeons. That is what probably some data, some few papers have shown us that,
So
because they
what
will
happens is I
probably be little like you take yourself for granted, and this thing, that is what has been shown in few papers.
They may get more complicated cases.
and you start doing more complex. Yes, I agree.
Yes,
So
yes.
I think 250 probably would have been a better number because you would have overcome all your problems and you will start, your experience will start counting. And also the what Niranjan said about the, taking for granted, all those things you will iron out because you realize that every new case is a different case. I think between 100 and 250, you are in that range where you think you can do anything, and then you realize you can't. You have to be more careful. So 250 would have been better to, for you to judge the surgeons as to whether their identification ability and things are good. So trainees probably not necessary and superfluous. So surgeons 100 probably not the correct number. And then the comparison at 4 frames to the number of frames that they have given for surgeons and trainees. I think I don't know whether they have actually done this, they validated it by the statistician or not, or whether we have not actually understood what they were actually trying to convey. Either of the two. But either of the two is wrong because if you write a paper, it should be very clear as to what inference you are drawing and what is the message. So if you are not clear about it, then the purpose of writing the paper is lost, or we are actually the data itself is wrong.
Yes, sir.
Sure. Nikita, show us anything you have, any other papers to justify
Support
your.
You have
this.
any other papers, ma, on
Sir,
AI?
no, sir. They actually commented on one paper, which was a study conducted by Mazad Zade. The accuracy of large anatomical structures as uterus was higher in comparison with the small anatomical regions they mentioned, sir. It was a different algorithm, which was about AI computer vision, sir. I found two other studies, but I couldn't find the results of the studies. They were not accessible. They did not
No, what did they in
bring
that
the results.
abstract? They would have given no conclusion and results
No, sir,
of
they
those
did
two
not
studies.
mention,
What
so
did
I
they say?
couldn't. They did not mention anything, sir. They just started the abstract and left it there.
But
Okay.
then there should be a conclusion. No?
So what did these people conclude?
These people concluded that Sir
Show that.
Smart is uh, w- mm, they also mentioned about their limitations, sir.
No, conclusion. Go to conclusion first and then limitation.
Okay, sir.
Go
Conclusion,
back.
they said that it can detect and localize more accurately, and in comparison with the trainee surgeons and experienced surgeons, it has statistical significance, sir. So they believe that well-trained AI system will be born soon and it will benefit the patients and surgeons, they mentioned.
Okay.
And
Hmm.
limitations, they commented on the number of cases. Yes, sir. And they said that they will be doing a laparoscopic, like 10,000 cases will be, with 10,000 videos of the cases will be collected. And they will feed the algorithm with those 10,000 cases and do it in a full multi-center project.
Yeah. So 10,000
And
probably would have been the ideal number.
Yes, sir. And
Sir?
even the questioning also for logarithm, they said that, and in questions also they said instead of 2 cases, they would want like more number of cases for comparison. These were the 2 limitations which they published them.
Correct. Anybody else has any comments or
How is this
Praveen?
when compared to the ICG?
Sir?
AI compared to ICG used lab coding. Is better to identify the structure.
Don't know because ICG we ourselves can see, AI we are not used any time
Yeah, in
until and
ICG.
unless we get probably a MRI or overlap into the systems of the patient. We if they can do an MRI and then overlap it to the system where we can identify the CBD
You have
accurately.
used ICG at hospital.
ICG we have used. Definitely ICG helps.
You have identified all structures correctly, no? So far.
Yeah. Most of the cases till now, what we have done, we have been able to identify the CVD and cystic duct and the other structures. We don't know about the AI.
I think
Ravishankar, sir?
I think what will happen is you will be able to, there will be a software and probably a plug-on to the this monitor and
It has
to the
already
system.
come on, I think, in neurosurgery where
So
they have mapping.
yeah, so you just switch it on, and then it will probably, in difficult cases, maybe it will guide you where the bile duct is likely to be, where the cystic duct and its junction and all these things. In difficult cases, I don't know whether it will come in next 5 years or whatever, or 2 years. We have to wait and see whether they will be able to bring a program like that, which will be an addition to the armament, as Srikanth said, in addition to ICG.
Probably it will come soon because already in neurosurgery they do that for accurate tumor dissection and all that, where they overlap the patient's images and into that intraoperative camera this thing vision, where they will be able to identify the different structures and also the adequacy of the resection surgical margins. So probably in other specialities also we might get that AI soon. We don't know how many years, but probably it is already in development.
Yeah. Any
So
other comments, Sanya? Abdul has not said a single word. He's not there.
he
Abdul
is
on call.
logged on. I don't know, but he's no. Nikitha is on call.
Abdul, are you there? He's not there, I think. Okay.
Is there, sir?
No, he's
Abdul
logged
is
on,
there.
but he's not commented till now. Whenever we have asked any
I
questions,
think again the speaker issue, sir. Because he's unmute also, but he's not able to talk.
Same problem, huh? You can't talk.
I think he has to update or this
No,
thing is
he used
Zoom
artificial intelligence to prevent
to
himself from
cleverly
not
escape.
talking.
Map the participants.
Right, I think.
Okay, I think if no more comments, sir, nothing else. No, I think we will conclude then.
I think tomorrow, Nikitha, Praveen, and Ainaz, and even maybe Sanya, all those tests that they have, statistical tests, you put up the, short note on all of them. I think it's very important that you guys do that. Okay.
These tests, I think we have not come across till now wherever we have done the journal club. And they all sound interesting, whatever the statistics they have used.
So please put it up. Okay.
Yes,
Good
sir.
night.
Good night,
Thank you.
sir.